Excellent. Afternoon, everybody, or good evening, depends. Welcome to the folate receptor alpha 1 interpretation workshop. This is in preparation for the circulation we are opening today. Excellent. Today, Adelina is with me and she'll guide us through this new biomarker. They're coming up fast, these biomarkers. We need to tell our appreciation to AbbVie, who is sponsoring this session for everybody. So thank you, AbbVie. And we need to tell you that AbbVie is not responsible for anything we say here. These are expressly our view on the subject. And this is our agenda. Our agenda is to speak very briefly about Tubo-Ovarian cancer, giving it a clinical context. We'll talk then a little bit about the folate receptor alpha and its role in cancer, and about this new drug, this new antibody drug conjugate that targets the folate receptor alpha. We'll look at the three really clinical studies that have reported about the use of this drug. There are lots of people coming in. Welcome, everybody. And then we'll go exploring really the assay. What does it look like? How do we interpret the section? What is the cutoff point? What are the pitfalls? How do we negotiate these new tasks? And then hopefully we'll do this in 35, 40 minutes. And then in the last 15, 20 minutes, maybe 25 minutes, Adelina's selected some cases which we can look at live and discuss the findings. Okay, these are our learning objectives. So especially the understanding the scoring algorithm for Tubo-Ovarian cancer, because this is a test that needs to be used for selecting patients for eligibility, and then perhaps how to implement it in your practice. Our immense, eternal gratefulness for Anne and Emilia, who provided a lot of these slides, and our long-term collaborators of CADQAS. Oops. So, Tubo-Ovarian cancer, ovarian cancer background. So it's, as you can see here, is a disease that presents advanced. And we know that because a lot of the patients in your clinical practice are always having advanced and are not really very suitable for surgery, and then they are treated by chemotherapy, and then eventually they become palliative. It is a significant problem with 300,000 new cases per year worldwide, making it the 7th most common cancer in women. And most of the patients with ovarian cancer, and this is any ovarian cancer, end up dead. And the projections is that the death toll will increase by 50% in 2040. The histology of ovarian cancer is can be derived from epithelial cells of the ovary, from sex cord, and so stromal tumor and germ cells. The majority are epithelial tumors, or tubo-ovarian carcinoma, that's TOC. TOC has 5 main distinct subtypes: the serous carcinoma, which is high grade and low grade, endometrioid clear cell, and mucinous. Most of them will be high grade.
We're basically talking about serous.
Yeah. And then, of course, we know about borderline and tumors. They all have a borderline category. Okay, so what is the treatment of high grade serous? High grade serous really needs an understanding on whether the tumor or the genetics of the patient result in susceptibility to homologous DNA recombination defects, that means that they will be not very good at repairing double-stranded DNA breaks, hence the type of therapy will be platinum-based and then perhaps also using PARP inhibitors. If surgery can be done, first line will be surgery followed by a maintenance regime of chemotherapy with taxane and platinum, if suitable, plus there is a heavy use of the anti-VEGF targeted therapy, and then there is a maintenance regime. I keep admitting people arriving late. That's okay. Okay, so these are the 5 subtypes, and you can see here the major contributor is the high-grade serous carcinoma. What are the options for these patients? So those that are BRCA mutated or have the defect of the homologous DNA recombination, so HRD positive, they will benefit from PARP inhibitors. And those not, they will be given other things like, for instance, paclitaxel and doxorubicin, etc. But essentially, and I have somewhere a diagram which I will show you in a moment. I don't know where it is. Essentially, these are not curative treatments. In most cases, the patients will go through phases of remission and then phases of active disease and then new treatment. It's a kind of chronic, really very much in inverted comma, because it doesn't last a very long time. So really, the context of this is that these patients will benefit from something else that work. So this is a little summary, and here at the end, this 4th point is about the fact that the folate receptor 1 protein could be a target for therapy because it's expressed in most tubo-ovarian carcinoma. And then here you see a typical patient has got periods of remission and relapses, and then you get into responses, and then eventually, even if your tumor was sensitive to platinum, then eventually becomes resistant to platinum, and then very little options after that. Okay, so folate receptor alpha. What do we know about it? It's folate, as you know, is a water-soluble vitamin and is essential for carbon metabolism. So if a cell has to synthesize DNA, RNA, that requires a lot of folates, and that the folate receptor alpha is a way of getting folates into the cell, and it's a cell member receptor is taken into by endocytosis, and then the folate released. Sorry, I keep getting lots of people.
We need to understand it's a membrane-bound surface.
Yeah, it's a receptor, so therefore has to be there. And in normal tissue, it's quite high in, for instance, embryogenesis, where there is rapid growth and division. And it's been known for a very long time, and in 1991 was isolated as a cancer-associated antigen in ovarian cancer. So the association with ovarian cancer is long-standing in our knowledge. And the folate receptor alpha expression is limited in most adult tissues because they have alternative way of getting the folate in. So it's something that is used perhaps earlier on in embryogenesis, but not very much in adult tissue. And this makes it an ideal combination. So it's highly expressed in tumors, not really present in normal tissue. So that's great to be. And you can see here, overexpressed in certain cancers. Here there are some proportions to be taken with a pinch of salt because it depends on how you define overexpression. Is it, what is this over 50%, 70%, strong, whatever it is. But you see major targets, and it's variable. And you see, tubo-ovarian cancer is probably some series, quote 90%, essentially almost all of them. But as we will see, the amount of it could be important for successful therapy. Okay, so so the key takeaway is it has a long-standing, we know about it being a cancer-associated antigen since 1991. There is very little expression in adult tissue, but the increased requirement of folate in cells like cancer cells means that some tumors overexpress it. It's a functional overexpression, and this can be used as target these cancer cells. And the targeting in this particular case, in the case of the drug we are going to describe, is not the disabling of the folate receptor, but is using the folate receptor as a Trojan horse, as a vehicle to go into the cell. Fantastic. And then obviously, because normal tissue doesn't really express this a lot, means that the collateral damage to normal tissue is reduced if we use this target. And then Ella here is the big name is this one here. I won't even attempt to pronounce. It's another one of these antibody drug conjugates. So there is a backbone, is a monoclonal antibody. I am not so sure whether this is humanized or recombinant, but anyway, it targets the folate receptor alpha. And then it has a payload, and these payloads, now we have learned, they can be associated with the antibody using different type of cross-linkers. These little dots here are cross-linkers. The strategy is that these cross-linkers can be cleaved by enzymes that are usually endocellular. So usually they don't get broken up while they're not inside the cells, and therefore the toxicity of these drugs is really reduced to the cells that incorporate it. Okay, so the payload is about 3 to 4 molecules per cell, not huge, but not insignificant. And all these antibody drug conjugates, there is always this bystander effect. Not so sure what it is, but maybe is the chemotherapy molecules released by the dead cell will go to the neighboring cells, even if they didn't incorporate it. Okay, so that's a kind of scheme of things to do: incorporation, the release of the chemotherapy drug, and then apoptosis, etc. Now, important, these things work possibly because you provide a very heavy payload of these cytotoxic drugs. Therefore, you need to have a high amount of receptors on the surface. And just empirically, this has been found to be a certain level of expression that we can detect by immunohistochemistry. And this is the basis in which we are going to use this test to select patients for therapy. So three really key trials. And as you can see here, some of them have reported, but a lot of them will report in the future, and they will be interesting to know because the indication and maybe the interpretation may change. This assay may change. So the three trials that really we need to talk about is FOLR1, Soraya, and Mirasol. This one was an early trial that used 50% overexpression as cutoff. There wasn't any significant expression.
Any difference?
However, when you do post-hoc analysis of it, you realize that if you pick up only the higher, very high expression, maybe there is a trend towards significance. So this one, not good. But then the next trial, that used a 75% cutoff with the moderate or strong expression. And these led to the FDA giving conditional approval in 2022. At the end of 2022, conditional approval really needs some confirmatory data. The confirmatory data came from Mirasol, again using the cutoff of 75%. And this meant that FDA gave full approval, and also it was approved by EMA in November 24. Some kind of data. This was FOLR1 with the two arms. One was the antibody drug conjugate, the other was essentially best chemotherapy treatment. This was second line or more, and randomization was 2 to 1. But as I said, the primary endpoint was not successful, which was progression-free survival. And this was the intention to treat population in the folate receptor alpha high population. You see, there is some difference, but the trial was not designed for this. It was a 50% cutoff, so it didn't work very well. So this is now the Soraya trial, where the threshold was raised to 75% strong and moderate staining intensity. And in this much smaller trial, there was sufficient difference in survival to generate, this is the data, to generate the accelerated approval. And then the Mirasol was the confirmatory trial that reported, I think in 2024, early 2024, this was a two-arm study, a bit more beefy in terms of numbers, same kind of structure, and
but different separation.
Different separation, and this is the kind of good. This is the survival, and you can see that the 50% survival here is around 13 and around 19 or so months. So there is a considerable. There is here in the data. I can't read it.
I think it's in months there. It's 12 months versus 16.
Okay, so obviously these are patients. So when we look at these curves, we always say, well, of course, but everybody succumb to the disease. But you need to think about these are patients that had at least 2 lines of treatment, maybe more. So if you can demonstrate an improved advantage for the treatment, and then you start using it earlier on, then you can obtain better benefits for this population. Okay, cool. So this one, it doesn't matter. So basically, these are the full approvals. And the important thing to think about is that throughout these trials, the test was an immunohistochemical test, which was the Ventana FOLR1 RxDX. We used to use CDX, companion diagnostic, now is RxDX. Rx stands for prescribing, and DX for diagnosis. So it's an assay that helps diagnosing and prescribing the drug as well. Okay, so what is the scoring interpretation of this assay? What are the staining patterns? What do we talk about? So remember that all these assays are not just the antibody, but they are a combination of all the chemicals that go into retrieval, staining, preparation, whatever. So it's now very difficult to take these companion diagnostic assays out of the machine, the very machine you need to use. You know, people try and do it, but it's always a laboratory developed test, and you need to act very carefully. I will show you some data about potential alternative way of providing this test if you don't have a Ventana machine. So what are the scoring criteria? In a nutshell, we need membrane staining in tumor. So it's a percentage of tumor cell staining. So we need to do whole slide assessment, and then with a cutoff of 75% or more tumor cells that have membrane staining. But the membrane staining is allowed is of 2+ and 3+ staining intensity. We'll see what it is. It has to be membrane. And then what are they? Is partial or complete, apical or circumferential in distribution? We'll see all these type of things, but essentially membrane staining. So if there is cytoplasmic staining and membrane staining that is strong or moderate, you can still score that cell as positive.
Yeah, if you can differentiate.
If you can differentiate. But there is only cytoplasmic staining that doesn't count. So that's a little bit of a problem sometimes when you have a lot of cytoplasmic staining, because we know how difficult it is to put a number in your head on how many tumor cells actually have membrane staining.
And the novelty would be that we score apical, even if it's exclusively apical.
Yeah.
Because we're used to circumferential or basolateral, for instance, in HER2. But that's the novelty, I think, in the
in the Tubo-Ovarian cancer, and we will see some of these cases in these serous tumors. Apical staining is strong. It's very much an allowable scoring pattern. Is this okay? We have some questions here. Is this similar to the interpretation of Claudine? Kind of, but not quite. And we will see why. I think now you will see that all these new biomarkers, we will need to learn the little staining patterns relative to the tumors we are studying. Because, including in gastric cancer, we had to learn those micro acinar type of patterns.
Perhaps if we start scoring FOLR1 in breast cancer, then we won't have something like apical as much as in ovarian.
Actually, this is an interesting point because you see, I think you saw one of those early slides that said, actually, this folate receptor alpha is ubiquitous in tumors. It's not just ovarian cancer or serous cancer. So it is possible that we will use this potentially for other tumor types. If
perhaps we need to adapt.
And to adapt our interpretation. Okay, as usual, necrotic tissue cannot be scored. If you have crushed tissue, that's going to be really difficult to understand whether it's membrane or not. So possibly you should exclude it from the scoring, or tissue with cauterized cells, etc., etc. And as you say, cytoplasmic staining only doesn't mean it's not a positive cell. Okay, so this is a kind of reminder. So the scoring intensity you see divided as 0, 1+, 2+, and 3+. Kind of instinctively, one would say, let's use the magnification rule. And I have to say, the magnification rule has been developed and evolved significantly well for breast. But now we have two biomarkers, FOLR1 and Claudin, where we kind of say, have a look at the color of the brown, very dark or black, kind of darkish, but not as dark. And this is very mellow, So do you remember when we did the other one, we said milk chocolate, factory chocolate, this kind of thing, or dark chocolate, this kind of chocolate thing. So you can see now that the interpretation guidelines start to talk about chocolate, because it's the color, but still there is a role for the magnification.
Do you think the size of the tumor cells could also interfere, plus the addition of cytoplasmic staining with the this rule, magnification rule?
Also, don't forget that we all love this magnification rule in breast, where we use an assay that doesn't stain very much. Is on purpose, is pulled back and doesn't stain very much. These are normal immunohistochemical assays. That nobody said let's quench it so that we don't show normal cells, for instance. So that was an artificial situation. Okay, fantastic. Let's see. So it's a little summary. Membrane staining can be apical staining or can be dot-like, all allowed, but cytoplasmic, no, unless you can also see membrane staining. Fantastic. So we were talking about pattern. This is a normal fallopian tube. I have to say, I have never found a normal fallopian tube staining so well, so diffusely. We will show you some normal fallopian tube. However, if you notice here, there is this strong staining intensity in the apical portion of these tubes, and then this lateral staining, maybe basolateral staining, weaker staining intensity. And kind of, if we go with chocolate, these things here are staining, but they are mellow. So this would be 1+. These things here are staining, but they're not as strong as this. This is 3+. And these ones would be 2+. And this is a mixture of 2+ and 3+. Yeah. And this is 1+. Yeah,
most definitely.
So it's kind of variable.
So this is used as control, but what do you think? We use the assay to identify the right fallopian tubes that have this intensity of staining, and then it will depend on the functional state, right, of the
yes, and we'll have a little discussion about this control, because not all fallopian tube will stain. We have another question. Is there a reason behind why? No, only apical staining in fallopian tube is not enough, no?
It's not.
Okay, so if we have a tumor that has apical staining, that's enough. But the fallopian tubes are not the target of our interest. It's just used as a control. There is another question. Is there a reason behind why more intense staining at the apical portion? I haven't a clue. Actually, if anybody knows, I'd like to know. Don't know.
So
Don't know really.
it
And
must
why-
have the relationship
and-
with the lumen and the fact that the membrane is enfolded as well.
Okay,
right?
but why is there folate receptor at the apical portion, which is in the coelomic cavity? What's
It's
the point?
It's in the cavity that helps with the procreation and secreting the.
I don't know. I mean, you would expect to come over from this side of the
It's definitely everywhere, whether we can demonstrate
We
it or
don't
not,
know.
because
We
we're
don't
not
know.
going to demonstrate it with IHC.
So I also have to tell you something.
That's a-
I also have to tell you something that although there is a theory behind it and the theory makes sense, etc., in reality, you need to think about this assay as being surrogate markers for selection of patients. This particular one seems to identify the target of the antibody drug conjugate, but doesn't necessarily mean that there are folate receptor alpha here on the surface, but the tumors that stay in here with this antibody are actually responding to the therapy. That's all that there is. You know, it's a correlation with response. Okay, so the situation is different from the situation of HER2, where we look at amplification over expression, and then the target is a molecule we try to deactivate by a trastuzumab antibody. Yeah. So this is just instead.
But do you think this is a good control? I mean, does it help us? Can we rely on it? Or since we have so much variability, or do you think we should create or design
to
cell
have other
lines?
cell lines? So, you know, we have very limited experience of this antibody as yet. Those that have worked with it more extensively suggest that we should use fallopian tubes and be selective in the ones we choose for the staining. We will show with Adelina some live cases where there are fallopian tubes and how you would interpret it. I mean, ultimately, instinctively, I would say that cell lines would be better for controls, but nevertheless, at the moment, I think fallopian tubes may be what we need. There is a nice comment that Adelina will read to us.
Yes. Yeah, someone looked up the reason why folate receptor is located in the apical portion. Reabsorption and transport. It's just like in the, so we actually also use kidney control for some of our cases, and it's kind of probably the same of reabsorption of folate.
Across a layer. Yeah. Thank you very much for enlightening us. Okay, so this is apical staining pattern in a tumor. You can see here that it's almost always, I think, associated with also membrane staining in the lateral portion of the cell. And as you can see here, some of this membrane staining is strong, some others is less strong, maybe moderate. But these cells providing this apical portion will score them as positive. And this is an example of dot-like staining pattern, which you can see here, these dots. They're not very small dots, probably the size of a nucleus. I think I have a higher power of this. Here it is.
Some of them are color. So are these microlumens?
They're kind of a little bit like the microlumen. Yes. Yeah. And they're associated with certain morphological patterns. And this is a cartoon showing why we would get this and then you should consider that all of these cells become positive. So when you see a dot-like pattern, the number of positive cells are quite a lot. You know, this is the apical pattern illustrated here. Okay, cool. And so that's another aspect to be wary of, the heterogeneity of staining, because there are some tumors that are all diffusely positive. You don't really have a problem. But as you can see in this particular picture, there are tumor cells that are negative, tumor cells that are weak positive, weak staining, so not considered positive for our algorithm, and some cells that stain a lot. So this, I think, is quite challenging, because sometimes you don't actually realize that there are non-staining cells, and that obviously there is a risk of underscoring, so overscoring rather, the assay, because you don't consider the denominator to be as big as this.
Some more comments in the chat.
More comments.
Yeah.
Just a moment.
With the dot-like pattern, how would you score this percentage? So I guess it's related to all the tumors that are around, all the tumor cells that are around the dot and contribute to that.
Yes, so you exactly. So you kind of, let's take these 3 dots here and think about all the cells that radiate around these dots. What really this is telling me is that this area of the tumor is all positive, because each of these, one of the cell touches the dot. If it touches the dot, it's positive. And some of them may be too far away from the dot and therefore not positive. So yes, so this is a tricky, not very common, but this is a tricky thing to interpret.
When we see dots that are basically equidistant over an area, and you think, well, all of these have all of these cells are around some of the dots. Sometimes you can't see the dots, but you would think this is all positive, this area.
You think it's all positive. So, and also in this particular example, there is very little membrane staining, at least at this magnification. This is very low magnification. It could be that if you look at moderate staining intensity lines, you find that there are also moderate staining intensity lines. There is another question. So that image is something like 75%. I would say this particular image, Richard, is one of those tricky cases that are around 75%. Adelina, what do you think? 75%?
We think that, of course, we would need to check a higher power. I mean, there might be areas that are negative completely, like this one over here.
Yeah.
But yeah.
Very few cells not touching.
Yes.
Yeah.
So Emilia, who is our greatest expert in this matter, says she thinks this is very much so. She would say 75% or more.
Over, yeah.
Okay.
Yeah, I would say when approaching a slide like that, I try to estimate the numbers of cells not touching a microlumina, and that is actually easier than trying to see how many cells that are positive, because they're not brown. It's more about them touching. So it's a little bit different approach when I'm facing a dot-like staining pattern. But I would say this actually is more than 75%, because there are only a few cells that are not in the neighborhood of a microlumina.
There are very few, yes, maybe at the periphery here.
Can I add another comment on the fallopian tube? Because recently CAP came out with a new biomarker testing reporting paper, and they also acknowledge that it's very hard to find fallopian tubes to function as control tissue, and they advocate also for moderately stained tumor.
Okay. So thank you, Emilia. That's very, very useful. So the emphasis, and we'll talk about it in the section, in the small section about the on-slide control. The emphasis is that we should put there something where a small decrease in analytical performance shows up as obvious, and we will not miss underperforming assays. Okay, so if we go through, how are we doing for time? A bit slow. Okay, so what do you do when you have heterogeneity of staining? I kind of, you need to decompose the picture. And here, Emilia has tried to encircles areas which are containing positive tumor cells that would be allowed as positive tumor cells, and areas that contain tumor cells that are not scorable as positive, and then try to understand what is the ratio and how do you come up with a number. And of course, you need to do this on the whole slide. So a kind of heterogeneity of staining intensity, it's a problem. Also, a problem will be when you find cytoplasmic staining, because it's kind of confusing. You have a tendency to say, oh, I think this is very positive, but then you realize that all of the cells that are brown are probably non-scorable,
And the deconstruction of the section I think is a very good idea. I have the same problem when looking at these cases. I feel like adding up the 1+ intense. So I really need to make an effort to kind of extract that. So I need to take away the 0 and the 1+.
And you know, this heterogeneity of staining, I mean, we're used now to try and provide a percentage or some kind of numerical output from heterogeneity of staining with PD-L1. That's what kind of happens, you know. And so we look at different areas which have different staining patterns, try to understand that staining pattern, what does it actually mean in numerical terms. And then, although theoretically we should have a ratio of cells, positive cells versus total number of cells, eventually we'll provide a ratio of areas because that's much easier and more affordable to do. Okay, so so the next bit, I think we need to speed up a bit if we want to see more cases because we are late. Yeah. What specimen to test? So the validated specimens are the tumors that are of ovarian origin, fallopian tube origin, or primary peritoneal origin. And the site of biopsies can be the primary site or the metastatic site. It doesn't matter. Any tumor tissue. And then what tissue type, FFPE, could be archival or new biopsies, could be resection or small amount of tissue. What it doesn't really work on is cytological samples, but many of us will start providing cell blocks with microbiopsies and then perhaps attempt to assess FOLR1 on cytology, but definitely also be wary of decalcified tissue. I mean, we spoke about these things many times in our seminars. If you have a bone metastasis, you can tease out tissue that is not calcified and process that separately. But if you have to decalcify something, do it in EDTA, fix it well first for 24 hours, and then decalcify slowly in EDTA, and you can retain positivity or immunogenicity, although I don't know of a study done particularly with FOLR1 test. And then the on-slide control. So if you have a cytology sample, don't fix in alcohol. We have a few more comments.
Post-chemo treatment.
Yes.
Are we talking about?
We're talking. We have a slide on post-chemo treatment. Well, some, yeah, and then about fallopian tubes. I think. Well, let's see if we have more usual things. We all know about immunohistochemistry. You need to reduce 10% neutral buffer saline. Don't be tempted because the fragment is very small. Don't be tempted to fix it for an hour or two because it looks fixed. You really need a minimum of 6 hours, and don't overstain for more than 3 days. Don't use first line alcohol-based fixative because they precipitate proteins and they become not as immunogenic for the antibody you're trying to stain it with. It says here, cut section of 4 micrometers. We don't cut at 4 micrometers. We cut at 3. But anyway, I use charge slides. The cast size stability has been tested for 45 days. It's okay. And be careful about decalcification. On-slide controls. We discussed this a lot about fallopian tubes. They will show us some fallopian tube. Theoretically, you should see crop-pot cells with stronger staining and apical staining and also side staining, lateral staining. But a lot of the fallopian tube may actually show no or very little staining, weak staining. Why do we want to put on slide control? Again, is to check that each one of our slides receive the right reagents. Also, it will help us identify a drop in performance from one run to the other because we use the same control, and therefore help us maintaining the quality of the assay that we set up. In our slide, in our own control tissue that you look at, you will see that there is no staining in the stroma, and that here is a little note. Really, when you look at it and you taste all your fallopian tubes, a small proportion will have the right amount of staining. and will be appropriate.
And we've
for
been
this
through
test.
that.
Yes. And I don't really know why. I don't know whether this is the result of poor processing and fixation, or whether it's a function of status, it's a function of age, it's a function of the hormonal status, etc., etc. Okay. This would be something that alerts you that the test has not performed well. Yes, there is still somewhat strong staining here. The lateral staining is gone.
I'm wary of this epical, thinking about the question earlier, epical staining only in all tissues. We know that there's so many, antibodies for which we get apical staining only if we have microvilli or ciliated surface. So that's another reason why it also shows stronger than in the rest of the cells and not specific really, because this is, I'm not sure it works.
Okay, so I think we can skip because I really want to go to the light cases just to tell you that empirically we've come to the conclusion that the most challenging cases will be the cases that show the percentage of positive tumor cells to be around these kind of mark, 65 to 85%. And if you look at the distribution of IHC results, they are not the majority, and then we can think about what do we do with things that are falling in the borderline. As we always said, a negative or a case well below the threshold, I think I can report without asking anybody. A case well above the threshold, I'm confident I can report. A case that is kind of maybe 75, maybe 80%, maybe 70%, I think I should ask a colleague to understand that we are all coming up with the right answer, with the same answer. Whether it's the right one or not, I don't know. So, okay.
I also wonder if the distribution of staining has an impact.
Yes.
If we think about that would be interesting to see.
So this was a little study that showed that of some of the challenging cases, there were some that showed the highest amount of spread. So there are parameters which we can identify that will give you some discordancy when more of you examine the same slide. So the staining intensity is 1+ or 2+. We talked about the threshold, is the percentage. The staining pattern, this apical staining pattern, the dot-like staining pattern, when there is cytoplasmic pattern. So if you look at a slide, so for instance, this is a microphotograph of a slide, and you clearly see that some of these could be quite weak, but some of this is quite strong. 75% is our threshold. Would this be 75%? You could try to deconvolute this picture by looking at each of these regions and trying to find out a number, a percentage for each of these regions. That's an attempt here. These areas have 2+ and 3+ staining intensity in most cells. So something like this I would call 95%, 100%. Something like this has got occasional cells that may qualify, maybe some dot-like, occasional that may qualify, let's call it, I don't know, 10% positive cells here. And then what is the surface area contribution of these cells to the overall tumor? And then you can see here, this is another staining pattern, and it has maybe 25%. These are some dot-like, etc., etc.
So basically, we can select areas with different patterns and then average them out also according to how much they represent.
And this is the kind of work we do when we assess a PD-L1 that is heterogeneous, isn't it? We try to put numbers to each one of these patterns, and
how
then
much
we kind of
the tumor is negative, how much is 1%.
Okay, so despite the fact that we are saying authoritatively and precisely 75% is the cutoff, you kind of understand that when you reach to something and say, oh, this is 75%. I mean, this is not really scientific, isn't it? Yeah. Cool. And that's another example of a tumor that has different staining intensity. Again, deconvoluted, find out numbers associated with each of the patterns, and then re-put it together. This is a slide to show you that there are alternative tests, but alternative tests don't perform the same as the companion diagnostic test that is related to the trials. This is a problem that we continue to encounter. There will be laboratories that don't have the right machinery to do this test. What do? Just be aware that other tests may not identify the right patients, and that is a big problem because you saw those data from the early trials. I mean, 50% positive tumor cells, and the trial was not significant. And if you have this kind of errors because your antibody, so this is something you need to consider. And no doubt we will see the emergence of blue or ring studies and then the blueprint studies to aid the use of non-companion diagnostic tests in those geographical areas where this is not available. So a few discussion points. I think I'm doing very badly with the timing, sorry. Do we do this test on reflex or on demand? What tissue to use and how to report? I think we'll do it very, very quickly because it's not that important. More comments?
Okay, so yeah, if we go to cases, we need to respond to that.
Okay. Sorry, we're reading comments.
Sorry, I don't think we're listening this.
Okay, in the interest of time, I'll get on with these few concepts. The first concept is, do we do it at diagnosis or on demand? Remember, these are patients that sooner or later will get to the point of needing to use some form of treatment. And usually, you know what happens. There is a scramble. If we are over here, there is a scramble to try and find a biopsy we can test, to try and get a folate receptor 1. So I am always of the advice that if you have a diagnosable tumor on biopsies, you provide all the data you can provide at that point. And then if nobody used the data, so be it, but at least the data is there for the patient, because how many times we know of cases of patients that are waiting for something that doesn't arrive, and then when you finally go to the patient, to the oncologist, say, I found a ROS1 mutation, they say, yeah, all right, but I can't treat the patient anymore. Is in intensive care, palliative. I'm not treating him.
Or so, we have a very bad sample from a metastatic site, usually aspirate on bone met, and then we can't find the blocks from the resection.
So it would be useful at diagnosis to tell the surgeon or the clinicians, I can't give you this data, take another biopsy. So consider this, and then let's skip these to say different type of histological type have different proportion of positive FOLR1 positive tumors, so above the threshold. And what do we do? So we have a small sample, is negative. Do I test more tissue? And what do I do with it?
If it's a small sample.
If it's a small sample, maybe yes, because it could be heterogeneous and I could find bigger areas that are positive and therefore does. So here are some thoughts, if you repeat the staining because you have a different biopsy, maybe you should give 2 different scores. The biopsy for 2023 is negative. The biopsy from 2024 is positive. Do what you like with it. But if you test additional block from the same lesion, maybe you should have a cumulative score, because it would be unfair to scramble and stain 10 blocks and then pick up only the one that is positive, ignoring the 9 are negative.
Blocks probably, yes.
Okay, but... so again, the decisions about when and how and what to test needs to be done in coordination with your clinical team as well. And then there is a tendency to have higher proportions of positive tumors when we test primary tissue rather than metastatic tissue. And hopefully I have something, not here, I have something to show that here it is, that show that after therapy, the expression of folate receptor 1 is lower.
Well, I think
that's therapy is the one that target folate receptor 1. There may not be such significant differences when you just use chemotherapy.
yeah, so Emilia's replied to that question, and she said that chemo doesn't seem to affect the FOLR1 expression.
Excellent.
But I think, was this tested on the pre-treatment sample? So were they all tested? They were
So the
all...
clinical trial only included pre-treated patients, but there are data where they tested pre and post chemo, and there doesn't seem to be a significant or visible reduction in FOLR1. Obviously, there has been also been done with an after FOLR1 targeted, and then you have a reduction.
Which seems obvious, isn't it?
Which is obvious.
Yes. Okay.
Yeah.
So very, very briefly, how would you report a FOLR1 test? I think you need to say what tumor are you testing, what is the primary, when was it taken, give some kind of referral laboratory number, make a comment on whether you think the tissue is adequate for assessment, and then state whether it's above or below the threshold for calling it positive, and then describe what test to use, etc., etc. It's just a suggestion of your report, and do make a point in telling why a test is not interpreted, or if you decide it's not interpreted, not tumor cells, brush, poor preservation, whatever it is, because it's important to say not interpreted rather than negative, because not interpreted means I don't know the status and I need potentially to do another sample. I would say also make a note if the assessment shows the percentage should be very close to threshold, and also you could say whether you share or you consulted with a colleague when you reported it. Also, share difficulties in interpretation, for instance, presence of cytoplasmic staining, heterogeneous staining, etc., etc. Stress that if you are looking at a biopsy of bone metastasis that is negative, even if it's not completely negative, and you don't know what decalcification has been done, you should consider reporting this as indeterminate, because you may have a low performance due to poor tissue preservation, and this tissue could be positive rather than negative. Okay, case study, Adelina. Finally, we only have a few minutes, so sorry.
I think we
more. Fantastic. We go here.
Well, this is like...
Show us fallopian tube, I guess. Okay, that's an excision.
Well, a serous carcinoma. Is it high grade? It is high grade. It has tons of mitosis. And I think this is where we've got, both controls of, so this is what I'm saying about the secretory surface as well. But I feel like the surface is not, perhaps is not very well preserved everywhere.
Maybe,
the ciliated, the brush border.
Okay.
So,
and there is not a lot of staining in the lateral membrane.
Weak to moderate lateral, and this is our good control, I would say, until now.
We have a bad,
stronger.
Do we have a bad control in it as well?
Not on this slide.
No. Okay.
But we do have a kidney, and this is what I think the reabsorption process is in proximal tubules.
Okay.
But again, this is one of the normal tissues that relatively expresses more than one of the few ones. And if we go to our tumor, this is, I think at a glance, we're at, can go for 5 magnification. If we want to use the magnification rule.
So here I can see little lines every now and again,
but it looks
which could be strong.
Very little though, but in the relation with the.
Could you give us a ×10?
I think this is where I am at ×10.
Okay.
So there's definitely moderate and strong, because we could see some at ×5, I guess, like this.
But affecting what? 5%, maybe.
Yeah, at most.
At most 5%. So a clear negative result.
Yeah. Okay. But this is more like apical, and you see these micropapillae, I think.
Okay. I'm sorry to hurry you. Let's get another nice case.
I think I have another one with apical
Yep.
staining that is a bit more. It's just for you to see. I'll go straight to the tumor.
Yep.
I think this is the better scanned one because we had to rescan these cases. Again, this at first glance in a given area that has apical staining all around, you would think, oh, this is actually not very much. But if we think that we have 2 cell thick micropapilla or trabeculate, then that means everything is staining on both sides.
Right.
If this is strong to moderate. So at first glance, you think, oh, it's not that much.
But
Well, of course, this is still, I would say,
do you think we are close to the threshold, or we are
still not,
below?
because this is the area that
Because
stains the most.
there are large areas or no
Yeah.
staining. Yes.
But I think we would do many more cases during our feedback session.
Are these little dots a little microcarcinoma? Maybe, maybe not.
Maybe this one
Maybe
is.
this one.
And
Yeah.
then we have these cells around, and these
Okay.
cells will all be positive.
Would you say it is also you would be
Negative.
negative, reporting negative? Okay, another one we can do another 2 if you're fast.
Okay, what case would you like? I have one with cytoplasmic just to show how
Yep.
difficult can be. I mean, it is, I think it was positive, this one, but
Okay.
or maybe not. Maybe it
This
wasn't.
is,
So
there are some lines, but is this necrotic material?
it's not, but it's a lot of cytoplasmic,
Lots.
especially in the weaker areas.
Yeah.
I don't see any distinct membrane here, for instance.
Okay.
So basically, it's only these. Is this membrane?
Well, that's what
Even
I
the
thought
stronger-
could be a bit of membrane staining here.
It could be, but
But again, if you
Very difficult.
have learned at this power and then you remember what it looks like, these areas are not very many.
yeah. Maybe here you've got more.
Maybe here there is more. And again, I'm not 100% sure about this. These look like just strong cytoplasmic staining with a non-staining nucleus.
Yeah.
Yeah. Okay. So although a low power you feel looks like a HER2, but it doesn't really.
No. But it seems like
and,
the moderate to strong proportion of cells,
and it's-
regardless, is less than
less.
70.
And it's interesting because you see, even when there is a bit more faint staining, you don't see lines. This is just cytoplasmic.
Yeah.
Okay. This could be pore preservation,
Yeah.
or occasionally there may be lines. Okay, so you think this would be negative? Give me, let's show a positive one for good luck.
8. Okay, it's coming here. This should be.
Okay, so you see, Adelina still uses the magnification rule for looking at it for intensity, you know. So she says, okay,
Guilty.
it's the time, but that's a helpful parameter. And you can go high power just to make sure that what you have seen is real, which I think we should do.
This is 5.
5, but 5, I think I see membrane staining here in
A lot.
a significant number of cells. But if you show us
Maybe
a higher
here
power,
is a
yeah,
weaker.
show us a high power so that we can say, yes, I do see membrane staining.
Yeah, I think there is a lot of dot like as well here, but
Yes.
we're less interested in that.
So Emilia is online. Emilia, what would you score this as?
Oh, I hate shouting out the scores like that, but this looks positive, right?
Very positive. Yeah. Yes. Fantastic. Fantastic. We are on the dot. I think we should stop sharing and leave the floor open for the last comments. Anybody wants to unmute and make some comments? And we have lots of people online, so I'm sure we will get the right answer for anything that anybody wants to. I have a question. How much does this cost? We don't know. Is this another one of those 200 pounds antibody? Oh dear.
I had another question.
Ah.
For such a high threshold, how much tumor should we have to give a reasonable?
So,
how
I
many
don't
tumor
know.
cells?
So I don't know, but knowing Ventana, they would have said at least 50 tumor cells.
Emilia?
Am I right, Emilia?
I can't remember, but I always think that that's like to the discretion of the pathologist, because the lesser tumor cells you have, the more random it will be.
Yeah.
So the more you have, the better.
Yeah.
And I don't know where these 150 cells comes from, because it really feels like sticking a finger into the air.
Emilia, one day they will shame us because they will show a scientific paper that analyze what happened if you have 80 cells, 81 cells.
Exactly.
Cells,
I'm waiting for that.
100 is the right number. I don't know. Very good. Okay, team. Thank you very much. I think if there are no burning questions, the circulation is open. I'm sorry the chit chat lasted so long and Ade couldn't show us more cases, but we'll see you at the case review in 2 weeks' time.
And then we'll add more cases.
And we'll add more cases. Okay, fantastic. Thank you all for participating.